Welcome to the Health Trip Podcast. My name is Jill Foose. I'm a functional medicine and integrative nutrition health coach. I created this podcast to bring you along as we travel down intriguing, science-packed roads, debunking old medical paradigms and perusing new innovative therapies and modalities with the finest functional medicine doctors, practitioners, and like-minded biohackers while living our best life. Enjoy the show. Hi, everyone. Welcome back to another episode on the Health Trip Podcast. I am continuing my quest to help educate women about breast cancer risk, preventative lifestyle interventions, genetics, and hormone therapy. About 90% of the women that I've had the honor to work with have never had a conversation with their OBGYN about hormone replacement therapy or BHRT bioidenticals. And about 50% of them have never had their sex hormone lab panels taken. Ladies, you cannot rely on your doctors to educate you because they themselves may not be fully educated on the current research surrounding breast cancer risk, menopause, and hormone therapy. Unless, of course, you're like me and you see a functional medicine doctor. As we age, our hormone levels drop. Ancestrally, we didn't live this long. Now we are. When our hormone levels drop, our risk for certain chronic illnesses increases exponentially, such as breast cancer, cardiovascular disease, osteoporosis, and Alzheimer's. Women my mother's age were going through menopause in the 1990s when the Women's Health Initiative study was going on. I've done a lot of podcasts on that study, so I'm not going to deep dive into that here, but the trial was stopped early, the study was flawed, and the false findings scared the bejesus out of women and doctors, leaving a multi-decades-long fear cast over women's health, hormones, and breast cancer risk. Today, my guest is Dr. Vered Stearns, professor of oncology, breast cancer research chair in oncology, and assistant director for faculty affairs at the Johns Hopkins School of Medicine. Dr. Stearns' long-term research goal is to improve current therapies by individualizing strategies for the treatment and prevention of breast cancer. Her main research includes the utilization of biomarkers to predict response to standard regimens used to treat and prevent breast cancer and to introduce new interventions. Dr. Stearns and colleagues were the first to evaluate the role of genetic variants in candidate genes such as CYP2D6 and tamoxifen metabolism, safety, and efficacy. The work has been extended to evaluate the role of genetic variants in aromatase inhibitor associated outcomes. She has also conducted clinical investigations of epigenetic modifying agents across the breast cancer continuum. Having demonstrated that methylation markers predict breast cancer risk, she is evaluating whether natural compounds can reverse these modifications. Dr. Stearns has received numerous grants and awards to fund her innovative research. She was a recipient of a clinical research training grant from the American Cancer Society, an inaugural recipient of the American Society of Clinical Oncology's Advanced Clinical Research Award, served as a board member of the National Accreditation Program for Breast Cancer Centers for the American College of Surgeons, and was elected in 2020 as a fellow of the American Society of Clinical Oncology. And she was selected by Forbes as one of the top 27 breast cancer oncologists in the United States. So that is a mouthful. And whether or not you got all that or not, she is well educated on this topic, and we are all in very, very good hands here. So let's sit back, have an open mind, and dive into breast cancer risk and genetics with Dr. Vered Stearns. Welcome, Dr. Stearns. I'm so happy to have you on the Health Trip Podcast today.
Thank you so much, Jill, for having me.
So I already did an opening talking about your training and your specialties and all the awards you've won. It was lengthy. It was extremely impressive. But just to share a little bit about yourself with the audience today, how did you become so focused on breast cancer research and your work?
Thank you for your kind introduction. I've always wanted to be a physician. This is going back to early childhood, but truthfully, I didn't really know what it entailed to become a physician. And as I engaged with my studies and then in my clinical training, I really got more and more passionate about treating individuals with breast cancer. And this was for a couple of main reasons. One, as at the time I was a young clinician, a young mother, and I was seeing a lot of young women with very complex breast cancer, and I wanted to do better for them. And it meant, number one, engaging in research, and number two, finding other ways to support them. And I was also working with some world-renowned physician scientists, and I knew that to truly make a difference, I had to engage both in clinical care and educating the next generation of clinicians.
It's an amazing journey that you've been on. And I've done quite a few podcasts on breast cancer risk and lifestyle interventions. And it's really interesting when people think about breast cancer, especially the women I work with in my health coaching practice, they automatically think of two things. One is family history, and the other is taking hormone replacement therapy. So I'm in that age. I'm in my 50s. I'm in menopause now, and I've elected to take hormone replacement therapy. I take the bioidentical version. My mother is a breast cancer survivor, and she was very much against me taking hormones. And I just wanted to get your thoughts on, are we right to think about these two scenarios, the family history and the hormones, when it comes to breast cancer risk?
So those are excellent questions, and we don't have all the answers, but I think our research will take us there in the near future. It's very important to individualize the decisions. So everyone is at a different risk, and everyone has different potential benefits from those interventions that we talked about. So the first thing that I hear from most patients with a newly diagnosed breast cancer is, why did I get that? I don't have a family history. I did everything right. Bottom line, we're women growing older in Western society. Those are the two major risks, being a woman and growing older. And it may be exposures to not just hormones and other things that we think about, and I'll talk a little bit more detail about it, but it could be other exposures, and it could be exposures that we had as we were growing up, or even in utero. So there's a lot that we need to learn about risk, how to assess the risk, and how to reduce the risk. More specifically, in terms of hormones, again, you need to make a decision why you're recommending hormones. If a woman is going through menopause and has significant symptoms and she cannot function, she cannot sleep, this is a woman who would probably benefit from some treatment. And there are a variety of different treatments, and I'm not going to go over those in detail today. But ideally, you want something that will be low dose for a short duration. So the days of giving hormones for 20 years are over. Most women will benefit from a course. It could be a few years, sometimes shorter, to get them through the transition. But as you mentioned, some women may be also at risk for breast cancer. So how do you reconcile that? Again, it's just being in close touch with your physician, knowing if you have a first degree relative with breast cancer, what was the age of that person's cancer, and how is best to do screening for you individually.
That's really interesting because in my opening, I had said that ancestrally, we didn't live this long. And so things are different now because we are expected to live these healthy, vibrant, energized lives until well into our 80s, maybe even our 90s. And so we have a lot of biochemical reactions in our body that are declining. One, our hormones are all declining, and our mitochondrial function is declining. We're going to get into that a little bit later as well. But you also mentioned, I know in some of your studies, you have done a lot of work on genetics and biomarkers and testing people to see what their risk is. Can you talk a bit about that, in terms of what biomarkers are you looking at, and how did genetics play a role in this?
So there are different biomarkers that we look at depending on the clinical situation. So when I think of breast cancer, I think of a few different scenarios. Again, being a woman, growing older, what are the risk factors? You mentioned hormonal factors, so other changes that we go through today that are different than how our ancestors used to live, or that we're getting pregnant a little bit later in life. Some women don't have any children. We know that being pregnant earlier in life, in your 20s, may be actually protective. There may be some differentiation in breast cancer cells that you don't see later in life, and that actually will be a risk factor. We have more uninterrupted periods that our ancestor did because we have fewer pregnancies and we don't breastfeed as long. So those are other factors that we look at. More specifically, in terms of biomarkers of risk, I think that sometimes our ability to do some testing and our ability to use them do not coincide. So we are able to measure hormones, measure other biomarkers. We're interested in inflammatory biomarkers, biomarkers of inactivity or obesity. And also markers within the breast density. We know that if you have dense breasts, that puts you at a higher risk for breast cancer. Well, what does that mean? Are those the ductal cells? Are those the microenvironment or the stromal cells surrounding the ducts? We actually don't know the answer. So more research will be required to understand the risk factors and how to intervene to reduce the risk in women who may eventually develop breast cancer.
Do you think it's a good idea for a young woman to do a deep dive into their genetics on the genes that are associated with breast cancer risk? And, what are the pros and cons to that? Because, when we're looking at genetics, and I do genetic testing, obviously not for breast cancer, but I do other lifestyle genetic testing, and it helps sometimes for the client to look at their results in black and white and then pivot their lifestyle in a direction that would benefit them long term. But the negatives are, obviously, if you see something maybe you don't want to see, and then you sort of have that anxiety or that panic. So what are your thoughts on early testing?
I think that, ideally, if we were able to know exactly what's going to happen to one person, we will be able to guide that individual in terms of interventions, whether those are lifestyle modification or medication to reduce an event we're concerned about. The problem with most of the genetic markers, they may say that you are at a risk for breast cancer, heart disease, diabetes, etc., but they cannot always quantify what the risk is. So you don't know, am I in the percent that's going to get that disease, or am I in the percent who's not going to have this disease? So to some degree, it depends what your intervention is. If it's an intervention that's good for you anyway, for example, we're going to talk about lifestyle interventions. Yes, people to eat heart-healthy diet, to exercise regularly, and do anything that reduces inflammation. It's good for our hearts. It's good to prevent diabetes and cancer. So those are good things we want anybody to do regardless of genetic biomarker. But if you have a gene that predisposes you for cancer, possibly, but the risk of cancer is just slightly higher than an average person without that gene, what might you do differently? We really don't want people to do radical interventions. For example, removing their breasts for risk of a future breast cancer. But compared it to a woman who might have the BRCA gene, whose lifetime risk might be 60 or 80% of developing breast cancer. And if that woman has seen a relative go through breast cancer treatments or potentially die of the disease, this woman is more likely to do this more aggressive measure. So we have to put it in perspective. So the key is to understand what we're testing for and how we use the data.
Right. And I was reading a study in Israel that the Ashkenazi Jewish women were all required to get tested or requested to test for the breast cancer genetics. And do you think that we should be doing that, like in the United States? I mean, I work with a lot of Ashkenazi Jewish women.
Yeah. So, so this is a question that is being, there are ongoing studies around the country and the world where people are being tested and the data are used to cancel them. I will tell you that my answer is a little bit more biased. And I think that because the BRCA1 and 2 genes are more common in Ashkenazi Jewish 2.5 to 4% of Ashkenazi Jews will have this gene. I think that it's something that could be considered for testing. Now, if you have a family history, especially individuals with younger age developing cancer, breast, ovarian, prostate, pancreatic, melanoma, those are individuals that I'll be more interested in knowing their genetic makeup. Ideally, we would start testing an individual who had cancer, because if that individual have the gene, then other family members can be tested. And if that individual is a gene negative, then there may be other risk factor for that tumor. I think my main concern about testing, though, is that we need to have the infrastructure to support the individuals who are positive and guide them.
Right.
For example, if you're BRCA2 positive, you may be at risk for breast cancer that is estrogen receptor positive, or ovarian cancer. And if you're male breast cancer, prostate cancer, or pancreatic cancer. So we need to talk about how to screen and look for all those potential tumor types. So it's not something that your average primary care doctor can do. And I fear that most of our cancer centers and genetic counselors are overwhelmed. So it's something that we need to deal with and find a way to provide the infrastructure to support the individuals. Now, I do want to mention something separate, and there are a lot of tests that people are doing. I'm not going to mention those by name, but they don't always have complete coverage of the genes. So I have people come to me, including relatives and friends. So I did this commercial test, and it says that I don't have the BRCA gene, but it might not look at every potential mutation. I want people to keep that in mind.
Yeah, no, that's good information. Before we move on from hormone replacement therapy, I had a couple questions. One is, if there's a family history of breast cancer and you're at an age where maybe you could be a candidate for hormone therapy, are there certain tests that you should take to find out more information before you make that decision?
There aren't specific tests that I would order today. I would look at the family history, what kind of cancer, what age did the first degree relative have the cancer, and then the woman is considering taking the hormones. What's the reason for taking the hormones, what different preparation she could be considering, and what type of monitoring needs to be considered. Obviously those are usually women in their 50s or late 40s. They will be doing regular screening images. Is mammogram good enough? Do we need to add something else? And so on.
Okay. And then what about women who are either going through breast cancer treatment currently or develop breast cancer? Can they take hormone replacement therapy as well during that time? Because there's a lot of women that complain about going through breast cancer treatment and having their quality of life really diminish in terms of, vaginal dryness, libido, painful sex, energy levels, things of that nature.
So again, it has to be individualized risk versus benefit discussion with individual women. If the woman has a high risk hormone receptor positive breast cancer, meaning the risk of cancer coming back is high, I'm a little bit more reluctant to consider hormones. But if her risk of recurrence is very small, she has considerable interruption with quality of life, we would start with, and non-hormonal treatments have not helped, we can start with vaginal preparation of estrogen that are low dose, and most to benefit from that. So it's pretty unusual to require high doses of estrogen. So figuring out what the needs are and what are the potential risks for the individuals. So again, it's hard for me to tell you what 1,000 women can do, but we can definitely guide individual women, and it doesn't have to be a no.
Oh, that's great. So we started to talk about what kind of lab markers you might be looking at. And you mentioned a few metabolic markers. And we're in November, it's National Diabetes Month. So I've been doing a lot of, putting out a lot of content this month on diabetes and lab tests to get. And it's very hard for people in the conventional medical healthcare model to go and get a deep dive into metabolic numbers. Like maybe they just get their fasting glucose, but they aren't looking at HbA1c or HOMA-IR, things of that nature. How important is it to gather this information, and how is that connected with breast cancer risk?
Would you know that women who have diabetes are at higher risk for breast cancer? And we know that people who are overweight or obese are also at high risk for breast and other types of cancer. And many times being overweight or obese is also associated with diabetes, high blood pressure, and other risk factors such as high cholesterol and so on. So I would say that many of the patients we see will have some metabolic assessment. So looking at lipid profiles, looking at fasting glucose, hemoglobin A1C, and so on. I would say that only women who have more known cardiac risk factors, in addition to breast cancer, we might be doing more comprehensive testing, whether it's more blood tests or a CT of the coronaries to look at calcium deposits. And I tend to work closely with one of our prevention cardiologists. In those instances, we also have a cohort study when we're looking at women who were diagnosed with breast cancer and the cardiometabolic profiles over time. Other things are bone health and many other factors.
Speaking of bone health, do you recommend that women going through menopause or even earlier get a DEXA scan to sort of get a baseline of where they're at in terms of body composition and their bone density?
And so a lot of this depends on the national guidelines and insurance. Almost every woman at the age of 65 or older should have bone density tests, and younger women should be considered for bone density tests if they have other risk factors, for example, if they're taking steroids or if they had early menopause. Many of my patients have either premature menopause because of chemotherapy, and then many women start medications that could reduce bone density, and all those women will get a baseline bone density test. You also alluded to body composition, and yes, you can use the DEXA scans to measure that, but it's not something that's done routinely. Sometimes we'll look at those retrospectively for research purposes, but there's definitely potential to help guide people.
Yeah, I'm all about gathering data. And I find that when I gather the more data for each of my clients, they really can look at the full spectrum of their health and make more educated and beneficial choices for themselves, for sure. Which leads me to the power study that you conducted on overweight women. I was hoping that you would be able to share some information about this study. I found it absolutely fascinating, just from a health coaching perspective, because you put in two groups, one group that were self-directed and one group of people who got to call in and work with, I believe, a health coach, but I'm going to hand that over to you.
Yeah, no, thank you for the opportunity to talk about our studies. We actually have a series of studies now, and I'll explain why we started this initial power study. So in practice, what I've seen that many of my patients with breast cancer, they've gone through multidisciplinary therapies and side effects, and they were struggling with weight. Some of them gained weight due to the treatment, and some came in overweight or obese. But and going back to something you said earlier, it's kind of a wake-up call, and they want to change their lifestyle. So it's a moment, a teachable moment for all of us. So many of my patients were really struggling. They were working hard, modifying their diet, exercising, and they're just not able to lose the weight that they wanted. So at the same time, my colleagues in internal medicine have completed and published a study where they compared in-person coaching to remote coaching to just self-directed weight loss. And they've shown that in-person and remote coaching were pretty similar. So we borrowed their remote coaching algorithms, which made it a little bit easier for people to take part. They had one-time meeting with a coach, and then we randomized the women. Half the women had regular follow-up with a coach, and this was individualized based on their own weaknesses and strength when it comes to diet and physical activity, and half just did their own thing. And we've shown the women in the coached group, about half of the women lost 5% or more of their weight, which was the endpoint of the study. And in the select-directed arm, a very few women lost weight and it wasn't sustained. We actually since completed another study when we included women who also had sleep disturbance, and we first randomized women to sleep intervention, so an intervention to improve the sleep before randomizing them. Sorry, the randomization was the sleep intervention, but then everybody got the behavioral health coached weight loss, and we're in the process of putting the data together. But let me also say that I still believe that there are women who work very hard and follow everything we tell them and have a hard time losing weight. And this is going back to my interest in biomarkers. What is it that make these women different, that are not able to lose weight with hard work? And those are some of the studies that we have ongoing now.
Yeah, I have so many questions about all of this. We could talk about this for a day, but I'm going to start with, what is the mechanism that's happening that causes overweight or obese women to be at a higher risk for developing breast cancer?
We may not know all the reasons. Again, we talked about a few things: higher levels of inflammatory biomarkers, insulin resistance, and so on. There's also probably some storage of estrogen in fat cells, and perhaps higher estrogen levels in women who are overweight or obese. So there are many potential mechanisms.
And what about GLP-1 agonists like semaglutide, Ozempic? Have you seen any correlation between having the overweight or obese women take these medications or these peptides that can help reduce the risk of developing breast cancer?
So those are definitely studies that are ongoing, and we do have a very strong group that helps individuals lose weight on our general internal medicine side, and we're collaborating on some studies where women are not able to lose weight on their own despite helpful coaching, will be receiving a medication in addition to the behavioral coaching. And whether we can correlate it with other markers of risk or actually fewer breast cancer developing or recurring, I don't know yet, but I believe we will.
That's really interesting. Because when I work with women who do all the right things, we get the labs done, we get the genetics, we look at micronutrient status in their cells, and they're doing everything, they're in, and they still can't lose the weight. And it's
exactly,
it's disheartening, and it takes an emotional toll on these women. So I do think there's the lifestyle intervention component, and then there's obviously a medical side to it. I actually take I take semaglutide, because even though I am a thin, lean person, I have half a thyroid that has affected my lipids and my insulin resistance and all those biomarkers for myself. And it has helped me lower my blood glucose and reverse my insulin resistance. And so I never thought I'd have to do that, being someone who's fit and healthy and lives that lifestyle. But it's not just about women who are obese or overweight. I think that women who are also lean should get as much of a deep dive and look into these biomarkers as much as women who are overweight.
Exactly. And we know that there's genetics or family history related to heart disease, diabetes as well, right? And again, I see patients all the time who say, I've done everything right. Why did I develop breast cancer? What's my risk of recurrence? Another biomarker that we didn't talk about, but we are very excited about and are investigating, is the microbiome. So the own gut, or maybe even in the breast tissue, may influence the risk of cancer, and maybe also changes in people based on their weight gain or loss. So we're looking at, in our weight loss studies, at the microbiome at baseline and then following a successful weight loss intervention. So that's something that, again, if we can show that people who successfully lost weight had a different microbiome at baseline, and were able to modify that, maybe there could be new medications that can be added.
Oh, that's really interesting. Speaking of the microbiome, let's talk about nutrition. Is there an optimal anti-cancer diet out there?
Well, what I usually tell my patients is that I support a heart healthy diet, and there are several, right? And sometimes it's what right or wrong for an individual. In general, a Mediterranean diet has been favored by many of my colleagues. And, what is heart healthy diet? So good proteins, that's more fish or chicken, not as much red meat, fruits, vegetables, little processed foods, and of course, in addition, regular physical activity. So I try not to be specific or dogmatic about what an individual should do, but lead them to several potential diets that could be helpful to them.
Do you see a difference in breast cancer risk when it comes to vegans and non-vegans? Has that ever been looked at?
I don't know of data. Could be. I cannot speak to that. But generally, if a person is committed to become vegan, we just want to make sure they get good proteins and maintain good body weight. We know that being underweight is not a good thing either.
Yeah, absolutely. And what about alcohol use? During the pandemic, many people turned to alcohol. We were stuck in our homes, and some people have not been able to change that habit that they had during the pandemic to now a non-pandemic period of our lives. So what's that mechanism that increases breast cancer risk for women who are drinking alcohol?
You're absolutely right. It's something that we've definitely observed both in our patients and our team members. It's something that would easy to add on and take pleasure. The mechanism is not well understood, and also some of the studies associating alcohol intake and cancer risk cannot completely differentiate the role of alcohol from other potential factors. And I'm sensitive to that because it's very hard for me to tell someone who been diagnosed with breast cancer and has a very good prognosis not to drink alcohol at all. And I'll tell you, there are some people who said that. And again, what I'm telling you now is my opinion and what we as a group have decided to tell our patients. So I think that probably having a couple of alcoholic beverages a week is a good number. I would try not to do more than 2, let's say 5-ounce wine glasses a week. And the mechanism, again, is not known. And when I refer to studies that making the association, a lot of them looked at very high alcohol intake, and people who have very high alcohol intake also usually don't have very healthy diets and may not be exercising regularly. So it's difficult for me to tell a person who has a very, very good lifestyle otherwise not to drink alcohol at all. So again, some alcohol in moderation is of interest. One of my colleagues is doing fascinating laboratory-based research to try and figure out whether there are what we call epigenetic modifications. Those are changes around the DNA, not within the DNA, are associated with alcohol use. And I'm excited to hear more about that from her.
That'll be an interesting study. Let's go back to sleep. And then we're going to talk about stress. Sleep and stress to me are two huge factors that if people can't nail those, if people cannot get that restorative sleep, especially as they're aging, and if they can't reduce their chronic stress, those two play huge roles in chronic disease. And I know you're doing this study on sleep, or you've already done the study. But what's that mechanism going on between poor sleep and increasing your risk for breast cancer or other cancers as well? And what do you tell your patients to do in terms of sleep hygiene? What are some of your favorite tips?
So poor sleep definitely associated with less physical activity during the day. It's kind of a vicious cycle. You don't sleep well, and then you're tired, so you don't want to exercise. Associated with more feeling of achiness, sometimes mood disturbance. You're just not feel like doing as many things, and those are all associated with high or due to high inflammatory markers. So anything that you can help a person to sleep better, they'll have better days and better quality of life, and they're more likely to be active and to pursue other activities of wellness. We do recommend starting with sleep hygiene, which is try to sleep in a room with very few stimulatory effects. So no lights or electronics. Try not to use any of electronics in an hour before going to bed. No TVs in the bedroom, ideally. If you can do a quiet activity, a meditation, anything that would calm you down before going to sleep, those are helpful interventions. And then, of course, people who have a harder time over time can talk to their physicians. We usually would start with something that has low potential for risk, such as melatonin, and go from there.
Do you know about the Uller pad?
No, tell me about it.
Oh, this is a great invention, especially for menopausal women who have hot flashes. But it's this pad that you put on your mattress under your sheet, and you can control the temperature. So there's been a lot of science behind 65 degrees as being an optimal nice temperature to sleep in. And you can actually set this mattress pad to I set it to 64 because I like it really cold. And if you have a partner, their side of the bed is controlled separately from your side, so they don't have to be the same. But this has just been a game changer in terms of sleep for myself. And I've turned a lot of my menopausal clients onto it. So it's called the Uller pad, and it's phenomenal.
That's a great tip.
Yeah. Yeah. What about chronic stress? How is that correlated with breast cancer risk?
So again, I do believe that chronic stress is associated with higher inflammatory biomarkers, and high inflammation is a risk factor for breast and other tumor types. So if people can have better balance in their lives and create activities that reduce the stress, if they can incorporate mindfulness or meditation or anything else that can reduce inflammation, and then exercise regularly, those are very beneficial. Of course, if it's figure out what's the major stressor, and that's something you can change, go for it.
Yeah, everything we've talked about comes down to this chronic inflammation in our bodies. And it's not just about breast cancer, but it's our risk for all different types of cancers as well.
Absolutely.
Yeah. What about when women are going through breast cancer treatment? How do you keep them motivated to continue eating right, exercising, meditating, like doing all the things they should be doing if they didn't have breast cancer, but now they have it and they have this other layer of, stress on their body physically and emotionally. So what's that conversation look like?
So what I try to do is, sometimes the very first visit is overwhelming, talking about prognosis and treatments and what we have to get them through. But I make sure to note of some of the other factors that we can work on if I'm not able to get to it in the first visit. And then as we start a treatment and we get to know the patients and the patient get to know our team members, we're trying to bring in slowly some of those interventions. So we deployed a behavioral battery questionnaire where we take a deep dive into more specific questions. I learn a lot from that, for example, on not just number of fruit and vegetable a person is eating, but the time they eat food, or binge eating, or fast food. And so we're taking a deep dive into more specific information. And then we created both research sheets and, if possible, clinical studies to try and address those needs. So we will send them to local nutritionists or other coaches that can help based on their needs over time. We've also have partnership with local gyms and have provided some yoga online and some other benefits. Integrative medicine interventions are very helpful as well. So we do try to bring in all of these to the individuals over time and support them.
That's great. What are your thoughts on fasting and reducing someone's risk of breast cancer?
So when you said fasting, you're talking about intermittent fasting?
Yeah.
Yeah.
Yeah. And there's all different types. Some people do a simple overnight fast. And I see a lot of women doing much more extended fast that I don't really subscribe to. But what are your thoughts on that?
Yeah. So, based on the scientific data that I'm familiar with, I think that there could be potential benefit, but it depends on the type of the fasting and the baseline. And there's a lot of hype about intermittent fasting, and I think just in general, it's good to have, a start time and an end time for. And late night eating is not a good thing. It also depends on what you eat, but some people already have relatively healthy eating behaviors, and intermittent fasting may not be helpful to them. To other people, intermittent fasting is just another way of calorie restriction. So this is why I think that those approaches have to be individualized. Now, there's interesting data about restricting or doing some fasting related to some of our treatments. And in fact, one of my colleagues is going to start a study with women starting chemotherapy. We'll work with a coach, a nutritionist, and have a fasting protocol before and up 24 hours after chemotherapy to see if reduce the side effects and if they're able to get their treatment more regularly. And there's some really interesting data behind that as well.
Oh, that is really interesting. What about the use of red light therapy? Have you seen any research on that in terms of reducing someone's breast cancer risk or helping while they're in chemotherapy in terms of reducing side effects?
I'm not familiar with the data.
That'd be interesting to find that out. I also want to talk about telomeres with you. This is something that my community certainly does not know enough about. I'm certainly no expert on telomeres, but I do know as we age, our telomeres are on the ends of our DNA. And I guess you can compare them to the shoelace with that little plastic cap on the end. That analogy is always used, and how that little plastic cap starts to fray. And then you see the threads sort of like fraying a little bit out. And so tell us more about telomeres, why it's important that maybe we get tested, because you can test and see where your telomeres are as you age. And why is that important in terms of breast cancer risk?
So a very nice description. And yes, as we age, our telomeres are getting shorter. And there's also data showing that people who develop cancer, the telomeres are shorter than other people their age. The question is how to test and who to test and what do you do with the data? And actually in the power study that I talked to you about, we did measure the telomeres at the beginning of the intervention and 6 months later with commercially available test that was developed actually at Johns Hopkins by one of my colleagues in our team. And I was hoping to see that the benefits of weight loss will also translate to lengthening the telomeres. Now, it was a small study and we're not able to show that, but it's definitely something that I'd be interested in seeing more research on. So, again, are there interventions that can help lengthen the telomeres, especially if you're diagnosed with cancer and your telomeres may be a little bit shorter than another individual your age.
Okay. So How important is it that we try to live our lifestyle toxin free? We have toxins coming in from our water, from our air, on our food, our skincare, our hair care. Is that a conversation that you also have with your patients in terms of, trying to clean things up a bit?
That's a very difficult question to answer because the data that I try to share with my patients come from our scientific literature, and I don't always have information about everything that we're exposed to. But I think more generally, trying to have whole foods and not processed foods, and trying to avoid exposure to multiple toxins is probably a good thing all around, right? Put your sunscreen on, and don't smoke. I mean, there are things that we absolutely know are associated with cancer, and there are some things we know less about. So I don't want people to remove everything that they might enjoy out of their life, but try to, again, really look at the scientific data, talk to their doctors or coaches and other people who can help them live the best possible life.
Yeah. One of the things I always recommend is, where you can control it, do your best. So in your home, right, or in your office. But when you go on vacation or you go to a work event, you can't control it. But if you can get a nice baseline and a nice foundation in your home for your family, that's always a great place to start.
Absolutely.
What are there any myths that you've come across surrounding breast cancer that our audience should know about?
I don't know there are any specific myths, but again, some of the things we already talked about is that, well, I don't have a family history, so I'm not at risk for breast cancer. Again, being a woman, growing older in Western society, you're at risk. And then just that we are very comfortable with taking pills to fix things, but sometimes it's the hard work, the lifestyle modification that.
Absolutely.
So again, when I see individuals with newly diagnosed cancer, it's a teachable moment, and we develop a relationship and we try to help them live their best possible lives. And ideally, anything you have control over that you can do on your own and doesn't require another pill is going to be beneficial.
Yeah. What about mammograms? How important is it for women to have a mammogram every year? I was reading a report in England how they're trying to change the requirement to every other year if there's no family history. So what are your thoughts on that?
So it's still the best imaging study we have today to look for early breast cancer. And the data come from multiple sources, and studies were done over many years in many countries. And for the most part, a woman who's not at the high risk with the factors we know about probably can have a mammogram every other year, starting at the age of 50 or so. And that's okay. The challenge is that we're not very good always at assessing risk and quantifying it. So there are models that you can look at family history and hormonal history and come up with a lifetime risk of breast cancer that can be used. But again, it's not something that gynecologists or primary care doctors are able to do. So in an ideal world, we will provide those tools and assessments and then decide how often one should have a mammogram, but we're not there yet. So I think this is why in the US, we're for the most part recommending a mammogram every year and in an earlier age.
Yeah. What about the automated breast ultrasound, the ABUS, for women who have dense breast tissue? How important is that? Because I have dense breast tissue and I was never told about getting this additional test done until just this year.
So only in recent years, and probably not in all states yet, we've been hearing more about the breast density as part of the mammogram report. So when the breast imager is looking at your mammogram, they will note whether the breasts look dense. And if so, it is a hint for the primary care doctor or gynecologist to consider another test. And either an ultrasound can be done, sometime an MRI. And it is very challenging because the ultrasound that's recommended is the entire breast ultrasound, usually be done by a physician, not necessarily a tech, which is what usually be done if you have a mass. If you have a mass in the breast, a technician can do an ultrasound of the area, but to do the ultrasound of the entire breast is a little bit more difficult, not always available. So it's just a challenge to our healthcare system, but I think it is something that needs to be incorporated more so.
Yeah. So before we end our podcast, what are 3 things that you would suggest women can do now, today, at home, to help either educate themselves about their breast cancer risk or move forward in preventative measures?
I think we probably covered most of it. I think the first thing is to know your history, your family history, and to talk to your doctor or coach about ways you can intervene and be in control to try and reduce your risk.
Mm-hmm.
I think the second thing is to know what are the screening approaches that are right for you. And again, what medical interventions or testing could be appropriate for you to diagnose a cancer early, such as a mammogram, such as a colonoscopy, skin check, and so on. And then the third is to just remember heart healthy diet and regular physical activity help reduce many illnesses and many types of cancer. As we look at the number of diseases that people are at risk for today, and cancers, many of them are influenced by the type of diets that we've been exposed to and being overweight or obese.
Yeah, all great points. Thank you so much for your time and attention to this topic. And we're very lucky to have people like you in the world that is researching and sharing all of this expert data on how we can prevent and reduce our risk for breast cancer. So thank you again for joining us, Dr. Stearns. And I will put in the show notes for everybody where to find you, find your team, find your clinic, so that they can look at all of your resources and contact you if they want.
Thank you so much as well for coaching many individuals and bringing the educational benefits to all.
Oh, well, thank you so much. All right. Thank you, everyone, for listening in. And I hope you enjoyed the show. Thank you for joining me. I hope you enjoyed the podcast. Lifestyle changes can be hard and overwhelming to make. By building your support team of functional medicine doctors, therapists, and health coaches, you can reach your optimal health goals. Be sure to check out my other podcasts. Until we meet again, stay healthy.